Thank you so much, sir. Good morning, everybody. I thank Dr. Pandey, sir, for giving me the opportunity to speak on congenital fibrosis of extraocular muscles. Uh, to be honest, I don't have a large experience in these uncommon cases. And the most, at the outset, I would like to tell you that one important thing which I want to put forward from my lecture is that the take-home message, I'm telling that in the beginning because that would set the tone for the rest of the talk, is that normally congenital fibrosis of extraocular muscle is taken as a mechanical or a fibrotic lesion, and things have changed over last few years, and it is now thought that we should take it in the light of neurological disease and not mechanical disease. So this is the previous classification. I have taken it from Dr. Hertel's article, which was published in Ophthalmology, which was on the unilateral cases. Okay, no, not this article. Okay, this is the classification of congenital fibrosis of extraocular muscle. The article was on unilateral fibrosis, blepharotosis, and ophthalmos syndrome. But these are the clinical entities, and it can be divided into 5 entities: generalized fibrosis syndrome, fibrosis rectus, strabismus fixus, vertical retraction syndrome, and last is the unilateral fibrosis, blepharotosis, and ophthalmos syndrome. But in 2002, there have been Dr. Elizabeth Engel's group and her co-workers. They have published a series of articles in the last 10-12 years, and they have now classified all these disorders, including the Devan's retraction syndrome and other disorders, together as CCDDS, congenital cranial degeneration disorders, where they believe that it is mainly the muscle development and the neurogenic etiology of congenital abnormalities of extraocular muscles and of facial innervations. And so they have demonstrated that the series of cases which are familial, and an individual which is diagnosed as having CFEOM based on the presence of congenital restrictive ophthalmoplegia that primarily affects extraocular muscle in the oculomotor nerve distribution. So now they classify them on the basis of genotype and phenotype. So the current concept which they have described is type 1, 2, 3. So type 1 and type 3 are not very different, except that this particular locus is affected. Phenotypical and genetic heterogeneity of CFEOM3 leads to 4th type, Tuchel syndrome, isolated anomalies, and one of the cases which Dr. Pandey sir showed, horizontal gaze palsy with progressive scoliosis, which is due to the ROB3 mutation. So type 1, I would be just touching upon the main things and the difference between type 1, 2, 3, Tuchel syndrome and other diseases, which would be important for the clinical practitioners to be able to divide it. We won't be ending up, doing a genetic analysis. So what are the clinical variables in these genotypes? The phenotypes which we see are mainly the down gaze and horizontal movements are restricted. Misdirected eye movements are common. Bilateral convergence on attempted up gaze, which is synergistic convergence. Globe retraction with attempted globe movement is there. Now, how do you differentiate it from type 2 is that abduction is present, but generally it is incomplete. Pupils often are variable in size and shape, and they are unreactive to light, even though they react correctly to the agents which we use. And neuroimaging would show that oculomotor nerves are absent bilaterally, so it is mainly, it behaves like a bilateral oculomotor nerve palsies. Type 3, very similar to type 1, except that it is more variable, the findings are more variable. And then there is, okay, we'll skip this. Okay, this is one of the cases which sir showed in the morning, the first lecture, his lecture, that there will be horizontal gaze palsy and there will be progressive scoliosis. The scoliosis progresses rapidly with the age, and this will show split pons. If you do a neuroimaging, scoliosis. Apart from that, you will see a cleft in the lower area of pons. Mobius syndrome is also included in CCDDS. Okay, these are the disorders, hereditary congenital ptosis and congenital facial palsies, which do not have normal ocular motility but have been classified with these disorders. This was one case which we had reported in IGO when I was. The case was from Arvind Eye Hospital, Coimbatore. These were 2 sisters, and you can see that patient had HGPPS, and along with that, patient had synergistic convergence. On attempted abduction, the eye comes inside. In both the cases, there is progressive scoliosis, and this is the pons I was talking about. There's a split in the pons. You can see here is the split in the pons. I'm pointing it out here. So you can see there is a cleft in the pons, and this was another case which we reported in 2006. There was a unilateral ptosis and anophthalmos in this child. The rare finding was there was a nasal glioma along with this. So that was reported by us when I was in Arvinda Hospital. I thank my co-faculty also. I'm privileged that I was with them. These are all senior guys. Thank you so much, sir.